Yes. Can you see my screen now?
Yes, Dr. Paari, we are able to see.
Yes, sir.
Okay, great. Thank you. So we have a fairly extensive soft tissue or orthopedic practice in our university. And I thought this was a great opportunity to share some challenging cases that we get in our practice. As Madam Vice Chancellor mentioned, the practice of soft tissue tumors is extremely challenging because it's a niche field. We don't get too many cases, and many of the cases that we get are very complex because a lot of benign tumors can mimic malignant entities, and malignant tumors can mimic benign entities with extraordinarily different aspect in management, right? And I also completely agree with her when she mentioned that the practice of soft tissue pathology should be a multidisciplinary practice, because so much depends upon the clinical findings as well as the radiologist findings in coming to the correct diagnosis. I hope I will be able to illustrate this with a few examples from my cases. Okay, I wanted to start with this picture. This is where I work. This is our university and its hospital buildings. And we are right by the river here. As you can see, this is the Mississippi River, and it runs, or it starts in Minnesota, in Minneapolis. So for case one, I have a patient who is 66 years old, and he presented with a firm swelling that he noticed in the dorsum of his right forearm for about 8 months. So he comes into the hospital, and as per protocol, an MRI study was done. So this showed a rather large soft tissue mass that was extending from the dorsum all the way to the volar aspect of the proximal forearm. Okay, and I will show you some of the MRI findings over here. And as I mentioned, you can see a rather impressive soft tissue mass, which measures greater than 20 centimeters in size. And this is the volar aspect. You can see a lobulated mass, very heterogeneous in appearance, areas of necrosis, and this mass extends over across to the other side in between the bones of the forearm. So we can see this better in an axial view, where you can again see the more proximal aspect of the soft tissue mass. It's fairly homogeneous in this region, and it's clearly deeply located, and it is extending in between the ulna and the radius and going over to the volar aspect. So here you can see that clear relationship to the bones. So the tumor is abutting against the periosteum of the cortex of these two bones, but it is actually not infiltrating into the bones. And you can also see that the tumor is not actually arising from these bones. Okay. Another axial view from the more distal aspect of the tumor this time, you can see the more heterogeneous part with the lobulations. And this also pushes up against the subcutaneous tissue and almost reaches the skin. So with these findings, the next step in the management of this patient would be to get a needle biopsy. And that's exactly what was done. A core needle biopsy was performed, and I will show you some images from the core needle biopsy. So these are all the fragments that we got on the biopsy. And as you can clearly see, this is a fairly heterogeneous mass. So there is an area over here that shows geographic necrosis. And then you have more cellular blue looking areas here and up top. And in this middle fragment, there is a combination of both fibrous zones and some cellular zones. And you can also see a little bit of hemosiderin. Okay, so let's take a closer look at some of these foci. So here, I'll focus on the middle part of these fragments, and I will expand this for you. So this is the portions that's been expanded over here, and here the stroma is pink and also a little bit myxoid. So there's a combination of myxoid and fibrous stroma in which we see a moderately cellular neoplasm, which seems to have a combination of spindle cells as well as some small round cells. It looks fairly innocuous. However, in the more cellular area, things are a little bit different. So you see quite heavy cellularity here. There is a sheet of cells. Most of them look small and round, almost like lymphocytes, but there is also some pattern. There seem to be some tubular rosettes or some pseudo rosette-like structures. And the background here is also striking. It's different from what we see here. It is quite myxoid. So if we look at more higher power pictures, right? So we can see the architectural pattern of growth. So here is a fairly non-specific architecture. Is essentially a sheet of these round cells embedded in this myxoid stroma. However, in other regions, you can see there is some pattern starting to appear. Here, there is a fairly broad trabeculae, here some narrow trabeculae, and then some cords of cells. Again, all embedded in a myxoid stroma. And then you see further enhancement of this pattern in this image with thicker cords and parallel arrays, a festooning appearance of these cells. Another image, the morphology changes a little bit. So you can see more spindling instead of the round cells, and you also start noticing some mitotic figures. So to study the cytology a little bit better, we go into high power, and in higher power, we see that the cells are fairly monotonous. They are round, with round nuclei, regular nuclear borders, and you do have some small nucleoli. And if you look carefully at the cells, you will also see many of them have this moderate to minimal amount of pink cytoplasm, which appears a little bit frothy in places. And then you also notice this mitotic figure and some apoptotic debris, which basically means, as you know, this tumor has a high proliferation rate. Okay, but in other areas, the cytology is also different. Here we can see the cells are not well spread apart. They are quite closely clustered together, and you may even be able to appreciate some nuclear molding pattern. Okay, and then of course we saw this large area of geographic type necrosis. We are just confirming that it is tumor necrosis in higher power because you can see the ghost cells over here in this necrotic zone. So at this point, what are the differential diagnoses we are thinking of for this tumor? Okay, let's go through the list one by one based on the various morphologic patterns that we saw so far. Okay, so the first diagnosis that I had in mind was an extraskeletal myxoid chondrosarcoma. So why did I think of this? That's because typically extraskeletal myxoid chondrosarcoma obviously will have a very myxoid background. And typically the cells are rounded, they are epithelioid, and they are arranged in clustered or cord-like or trabecular or festoon pattern. And I think that's the image that we are seeing in many of these fields here. In addition to that, you also have the cytology. The cytology of EMC is also typically like this. It has these small round nuclei, and it has a focal eosinophilic thin rim of cytoplasm. And that's what we are seeing here. So that is definitely a possibility. What are the other possibilities? So whenever we think of extraskeletal myxoid chondrosarcoma, another tumor that closely mimics the morphological characteristic of EMC is a myoepithelial carcinoma. Okay, so we need to consider both of them together, and we need to use ancillary tests to distinguish between these two. So what other differential diagnosis? How about Ewing sarcoma? Of course, because you're dealing with a small round blue cell tumor, and we also saw areas that were different from here, and we had these clusters of cells, the small round blue cells closely packed together, and in these areas, we did not even see nucleoli. So we might be thinking of a Ewing sarcoma, and that's definitely worth exploring. And then lower down the list, we want to consider this tumor called the low-grade fibromyxoid sarcoma. I say lower down because we only saw focal areas that look like this. We obviously have a fibrous and myxoid stroma over here, and we see some bland looking spindle cells, and we see some more spindle cells in other areas. So these are the differential diagnosis. But what if it's not any of these? What other myxoid looking small round blue cell tumor can we consider in this setting? So that's the question we ask ourselves after studying the morphology, and then we have to go to ancillary tests to answer this question. So we start with a basic panel of immunohistochemical stains. So we'll start with keratin, and you can see keratin is completely negative. And the next stain is S100, and you can see even that is completely negative. So a negative keratin and S100 essentially tells you that's most definitely not myoepithelial carcinoma, right? So at least that we can rule out. And then another basic stain, we do desmin. Maybe this is a rhabdomyosarcoma, like an alveolar rhabdomyosarcoma. We want to rule that out, and you can see that desmin is completely negative. So that's not the diagnosis either. And because we were thinking of fibromyxoid, low-grade fibromyxoid sarcoma in the differential diagnosis, MUC4, as you know, is a very good stain for that. And again, you can see this is completely negative. Another very basic stain that most laboratories can perform is a CD99. And as you know, CD99 is a very non-specific marker, and it stains so many things. But it is very useful if the context in which it is used is appropriate and you know what exactly you're looking for in CD99. So what do I mean by that? So CD99 in this tumor, you can see that there are some cells that are definitely strongly positive with a membranous pattern, right? But most of the other tumor cells are positive, but it's weak, cytoplasmic, maybe membranous. So there is a heterogeneity in the staining pattern for CD99. So let's assume we are looking at Ewing sarcoma, in which CD99 was first described, and it became a very popular marker decades ago for the diagnosis of Ewing sarcoma. So how does Ewing sarcoma show up with CD99? Here's an example of another case, which is a Ewing sarcoma. And if you do CD99 in this is the pattern you should be seeing. It's a diffuse, strong transmembranous pattern, almost every single cell, almost like what you see in 3+ HER2 for breast cancer. That's what you should be seeing in CD99 for Ewing sarcoma. And that's certainly not what we see here in our tumor, right? So it's unlikely to be Ewing sarcoma. And then the other stain I really like for Ewing sarcoma, which is very sensitive and fairly specific, is this marker called NKX 2.2. NKX 2.2, as you can see in almost all Ewing sarcoma, should be strongly diffusely positive in a nuclear pattern, right? So in this tumor, NKX 2.2 is completely negative. Okay, so with this immunohistochemical staining pattern and with our differential diagnosis, we need to go a little bit further. And since our primary differential diagnosis included Ewing's and extraskeletal myxoid chondrosarcoma, FISH test is a really good approach, next step, to see what the diagnosis could be, to either to confirm or to exclude the differentials that we have in mind. So EWSR1, which is what we expect to see in Ewing sarcoma, is negative for rearrangement here. So you can see the two alleles here with the green and the red probes, green and the red together. So there is no break apart of the EWSR1 gene. So we see them together. So this is a normal FISH study for EWSR rearrangement. In addition, EWSR not rearranged also tells us that this is not extraskeletal myxoid chondrosarcoma, because as you know, most extraskeletal myxoid chondrosarcoma have rearrangement of EWSR1 gene. And the partner, of course, is going to be different than what we see in Ewing sarcoma. And we did a FISH test for that too. And the partner in EMC is typically NR4A3. And this also was negative, okay? So with this information now, it becomes a little bit of a head scratcher. So we have to do additional tests to figure out what this tumor could be. And the first additional test I did was this additional immunohistochemical stain, which, as you can see, has some robust positivity in a nuclear pattern. And this stain is actually WT1. So carrying forward with this idea, with that particular diagnosis in mind, I also did another stain, which you can see right here, again, diffusely and strongly positive, but this time in a both nuclear and cytoplasmic manner. So this stain is actually calretinin. So this seems to confirm the theory that I had in mind. So to follow up on this theory, we need an additional FISH test to be done. And this FISH test is for the CIC gene. CIC FISH was done. And as you can see over here, here's the negative control for CIC FISH. And we don't see any break apart over here. The yellow, the red and green are together. And here's the positive control where we see break apart of the red and green signals. And this is our case where we see the break apart. So this proves that CIC is indeed rearranged. And this was followed by next generation sequencing tests to confirm that this is indeed a CIC rearranged tumor, and it indeed showed a CIC DUX4 fusion. So at this point, the diagnosis is clear. This is a CIC rearranged sarcoma. So what do we know about CIC rearranged sarcoma? So this is was originally described as a small round blue cell tumor, or as a Ewing-like sarcoma, because as you saw, it has some features that actually resemble a Ewing sarcoma. And this tumor, or this fusion-related sarcoma, was first described in 2006 by Drs. Nakamura and colleagues, where they showed a Ewing-like sarcoma had fusion between these two genes, the CIC and DUX4, and it also upregulates the PEA3 family of genes, which is in fact used as a good immunohistochemical marker. ETB4 is a PEA3 family gene, which is upregulated in this tumor, which can be used as a really good immunohistochemical surrogate. But after that, we did not get too much information about this tumor till Dr. Antonescu did a large study of about 115 cases. Okay, so we'll get there in a second, but important to know is these tumors are by default, or by definition, negative for EWSR1 mutation. So if there is a EWSR1 gene rearrangement, it is not a CIC rearranged sarcoma, they are exclusive. So as I mentioned, these tumors are characterized by the CIC gene fused typically to the DUX4 gene and chromosome 4, can also have other rare genes that are fused to it, but CIC is a constant partner. So this is the paper I was talking about that Dr. Antonescu and colleagues published in 2017 with a very large study of the CIC rearranged sarcoma, about 115 cases. So we learned a lot from this project. So we know that this tumor typically occurs in younger patients in their third decade, although if you remember, our patient was 66 years old. So this is an outlier. So you can get patients in an older age group too, but typically it occurs in younger patients in their third decade. And as it happened in our case, the deep soft tissue of the extremities is a classic location. And another important thing to remember is these are very aggressive tumors. And the prognosis is much poorer than Ewing sarcoma. This is important to know because most of these tumors are now were classified as Ewing-like sarcomas, and our oncologists were treating them like Ewing sarcomas, but the response rate was much poorer than we saw in Ewing sarcoma. And then the other thing for us as pathologists to remember is that the morphological heterogeneity is very, very common. We saw quite a bit of an example in our case as well, and I want to illustrate this further with more images. So this is a classic appearance of, I would say, a prototypical CIC rearranged sarcoma. So what you have here is essentially a small round blue cell tumor in a myxoid background. So that myxoid background is often a very useful clue. What differentiates it from Ewing sarcoma, even on morphology, is the fact that you do get a slight amount of pleomorphism. If you can see, there are some larger cells and there are some smaller cells here. Usually you don't see that in Ewing sarcoma that much. And in many cases of CIC rearranged sarcoma, you also see prominent nucleoli. In this particular case, the nucleoli are not that prominent, but you do spot nucleoli rather easily. And then you also see a little bit more cytoplasm than you would see in Ewing sarcoma. Usually the cytoplasm is pink to pale, and you can also see a little bit of vacuolation. Many of these cells have small to moderate amount of cytoplasm, which is more than what you would see in Ewing's. Other morphological variation, this is quite dramatic. You would never see a picture like this in Ewing's. It's very, very myxoid, the stroma, and the cells are quite inconspicuous. One might even mistake these for myxomas if you have a small biopsy. And then, as we had in this particular case, unusual architectural patterns such as trabeculations, cords, or small tubular structures can also be seen. And once you see this, extraskeletal myxoid chondrosarcoma comes into the differential diagnosis. And then we also saw spindling of the tumor cells that can also be present. And some cases do show substantial amount of pleomorphism, as you can see here with apoptotic figures and mitotic figures and all that. And Dr. Antonescu also showed that in their publication that many of these cases can have epithelioid morphology, as you can see here. And it's very easy to mistake these for poorly differentiated carcinomas. Of course, they are not going to be positive for cytokeratin, but at least morphologically, they may resemble carcinomas. So there is heterogeneity, not only in morphology, but also in their immunohistochemical staining pattern, which we can actually use to our advantage. So as I mentioned before, the CD99 staining pattern, even though it's weak and patchy, it actually does help us in thinking, okay, maybe this looks like a Ewing family of tumors, but maybe it's not Ewing's because it's not staining like a Ewing's. So this is a typical pattern of CD99. And the NKX 2.2 is typically negative, as we saw in our case, but some cases of CIC sarcoma can show focal or patchy staining for NKX 2.2. And the same is true for WT1. You might get a diffuse staining, or you might see it only in focal areas, and also for calretinin. So in this particular case, this is a different case than what I showed. You can see only a few cells that are positive for calretinin. Then the marker that is most useful, if you have it in your lab, is actually the fusion partner, which is DUX4. DUX4 is always going to be overexpressed in CIC sarcomas that have fusion between CIC and DUX4 gene, and that can be used as an immunohistochemical stain. And you can see that Dr. Antonescu's paper has showed DUX4 is strongly diffusely positive for these tumors. So in summary, what do we need to know about CIC rearranged sarcoma? It is typically a Ewing-like sarcoma that occurs in young adults in the deep soft tissue. And the myxoid background is an important feature here. And it obviously has small round blue cells. And the CD99 is going to be patchy. And by default, it's going to be negative for EWSR1 FISH. And if we want to use immunohistochemistry to help us with the diagnosis, the best markers I would suggest are WT1. And then if your lab does have ETV4 or DUX4, these are great markers as well. But ultimately, the diagnosis relies on proving that there is actually a CIC gene fusion, which you can either do by FISH or by next generation sequencing. And as I mentioned before, these tumors have an aggressive clinical course. So the 5-year survival is much poorer compared to Ewing sarcoma, is between 40 and 50% compared to a Ewing sarcoma of those have a survival of around 60–70%. So, and we actually saw this in our patient, quite unfortunate. So you can see this additional MRI image, which shows this tumor has metastasized to the axillary lymph nodes, and there is also a metastasis in the lung. So that brings me to the end of case one. Be happy to take any questions or comments before we go to case two.
Sir, good morning. This is Dr. Chandramolleshwari. Hope I'm audible. Can I ask you a question now?
Yes, please. You're quite audible.
Yes, sir. So actually in that CIC, that's for rearrangement sarcomas, like there are a few literature reviews which say that like IHC is supposedly more reliable when compared to fish. So your comments on that, and based on your experience, how do you rate it, sir?
Yeah, that is an excellent question. So the reason for that is fish is difficult to prove for CIC sarcomas because the break apart probes for the CIC fish is very difficult to interpret. It's not like the break apart for Ewing sarcoma where the genes are far apart. So it's going to be very close. So your fish pathologist has to be very astute in looking for even small break apart. So that way CIC sarcomas may be missed by fish. So that is the reason why next-gen sequencing to actually show the fusion or IHC might be a better test to show. Fortunately, there is no IHC for CIC as such, but as I showed you, DUX4 is an excellent surrogate for diagnosing the CIC sarcomas. Yeah.
Thank you so much. Thank you.
Dr. Paari, excellent case. One question, I'm Dr. Sandhya here. What
Yes.
are the morphological clues in a routine Ewing sarcoma that would kind of make us think of this as sarcoma?
Yes.
Because here we cannot do for every case. So can you just point out some markers in the morphological?
Yes. I can go back to my pictures to show you those again. But typically, when you come across a small round blue cell tumor with a myxoid background, then you need to pause and start thinking about either a CIC or something like a B-cord sarcomas. So those can show that kind of morphological heterogeneity. And even in a small round blue cell sarcoma, if you start seeing a little bit of pleomorphism, if you start seeing some nucleolar prominence, if you start seeing a little bit more cytoplasm than you expect, then it's time to start thinking about CIC rearranged sarcoma rather than just Ewing sarcoma.
Thank you. Thank you so much.
Yeah. All right. If there are no further questions, we can move on to case two. So this patient was a much younger patient than our previous patient. She was a 38-year-old female who presented to the ER with abdominal pain. And at that time, there was a clinical suspicion that it was going to be appendicitis, but it had to be proved, so a CT scan was done. CT scan actually did not show any appendicitis, but instead showed a mass in the kidney. And the radiologist thought that this was most consistent with a renal cell carcinoma. Now, renal cell carcinomas are not that common in patients in their 30s, but certainly they do occur. So this is a good differential diagnosis. So let's look at the image. So here you can see on the left side, on the superior pole, a mass in the kidney that's hypoattenuating, as the radiologist mentioned, and it does look like it's infiltrating into the renal parenchyma. It's not exophytic, it's confined to the capsule, and a peculiar feature that you can see here is that there are some calcifications, rather large punctate calcifications, not like the psammoma bodies that we might see in a papillary renal carcinoma, which are not even visible on radiology. So unusual picture, and that too in a 38-year-old patient. So needle biopsy was performed to make the diagnosis here. And again, as we saw in the previous case, we have multiple fragments of tissue with a heterogeneous morphology because we have some areas that are highly cellular here and other areas where it looks like mostly stroma, it looks mostly collagenous with maybe some myxoid features. So let's take a closer look. So this is a field from the area where the cellularity was higher. You can clearly see the glomeruli and some tubules in the background, and there is an infiltrating mass. So this tumor is highly infiltrating between the glomeruli and the tubules, and it is quite cellular. So if we go into higher magnification, you can see that it's a rather monotonous picture. So most of the nuclei, they look rounded, they look bland. I don't see any mitotic activity. They almost look like they are maybe lymphocytes or something like that. So very interesting picture, not certainly what you would expect for the most common tumor of the kidney, which is a clear cell renal carcinoma. It does not look like that. And the infiltrative pattern is also not quite typical for renal tumors. And then higher power at some other areas, you see a sort of almost like a desmoplastic stroma, again with these small lymphocyte-looking cells infiltrating into this desmoplastic-looking stroma. And again, another view of the stroma, which highlights that it has some myxoid features and some collagenous or fibrous features. So at this point, with this information, what differential diagnosis should we be entertaining? At least from my perspective, I was thinking of the possibility of a renal lymphoma. These are uncommon, but they do occur, especially patient is too young for maybe your typical renal cell carcinoma. And maybe it's not even a lymphoma, maybe it's just chronic inflammation and scarring. So unlikely, but that's another possibility. But both of these are easily ruled out by CD45, which is negative. So what about primary renal uncommon tumors? Renal carcinoids, these two exist. We've seen a few cases, and renal carcinoids may have these small round clusters of cells. That's a possibility. Although the organization in sheets is unusual for carcinoid, the infiltrative pattern is also unusual, but we need to consider that. And of course, we should be considering renal carcinoma, maybe with a solid growth pattern, unusual growth pattern. Clear cell carcinomas often have different morphologic appearances, so we should consider that. But both these, again, are easily ruled out by doing a cytokeratin stain, which was negative in this case. And then other unusual tumors in the kidney, like maybe a juxtaglomerular cell tumor, that was also unlikely here because typically these tumors present with renin elevation and hypertension, and there was no such symptoms in this patient. And it was also negative for c-KIT, which is usually positive in juxtaglomerular cell tumors. Maybe a melanoma. So melanomas can occur anywhere. Maybe it's metastatic to the kidney. They can have varied morphological pictures. So it's essential to rule that out. But S100 was negative. That's a very good screening marker, as you know, for melanoma. Okay, so what other tumor could this be? Of course, we're discussing sarcomas. We need to think about sarcomas. So could this be some kind of an unusual sarcoma that's presenting in the kidney? Before we started doing stains for this, digging around in the history gave us some more information. This patient did present to the hospital 7 years ago with a swelling in her left calf. Okay, and this swelling was a quite large swelling, and the MRI showed that. As you can see here, it's almost a 20-centimeter tumor that's deeply located in her calf muscle, and it also has heterogeneous imaging characteristics, maybe some necrosis in there, or maybe some regions that are hyalinized or something like that. And then in the axials, you can again see similar features to what we saw in the previous case. This tumor is abutting against the cortex of the tibia and the fibula, but it's not actually arising from or infiltrating into these bones. So after this was identified, the patient had a biopsy diagnosis, and they were surgically resected, and they received postoperative radiation for this. So I managed to get some images from the surgical resection specimen, and I will share those with you. So here we can see some parts of the tumor that are quite unremarkable. It basically looks like some type of scar tissue. It's densely collagenized, and I can barely see the nuclei in here. They look very bland. And over here, there is a little bit more of a myxoid change. Again, the same cells. I also start seeing some vessels coming up. And then in this field, we see some alternating myxoid areas as well as some fibrous areas. And again, the spindle cells that are barely noticeable. So let's take a look at a higher power picture. So this field is actually moderately cellular compared to the other field. Again, we see some myxoid and fibrous areas, which is further highlighted in this higher power picture. So there is quite an imperceptible transition between the myxoid and the fibrous zones. In the cytology as such, we can see what we guessed from the low power. It is quite bland, ovoid nuclei, fairly regular nuclear borders. The chromatin is also, fairly uniformly distributed, quite fine. I don't see any nucleoli. I don't see mitotic activity, no necrosis, nothing. So this looks like a very bland, low-grade type entity, but we keep remembering that this is a huge tumor in a deep location. So let's look at some more areas, some more architectural patterns here. So this one is a little bit striking because it has this whirling or swirling or whatever you want to call it, or cartwheeling type of pattern. And in this, it is quite drastically different from what we see in this field because obviously there is quite a bit of myxoid change in the background. And we also start seeing some delicate curvilinear blood vessels. And then another field shows these bundles of collagen that seem to be rounding up into balls, which is quite distinct from the other areas. And then there are also areas where the cellularity is obviously increased. And in these areas, we can see the myxoid background again. And there are also some coarse blood vessels this time, not fine blood vessels like this, but coarse blood vessels. So very intriguing morphology. So if we focus on the areas where the cellularity is higher, we notice some more features. So here is a zone of transition between the low cellularity, fibrous and myxoid areas to the higher cellularity areas. So you can notice here that the ATPI is also increasing. I see some cells with irregular nuclear membranes and hyperchromasia. Okay, so and here you can see more of those cells with perhaps an increase in cellularity. And in other foci, you actually see some really ugly cells with multilobated nuclei, look quite pleomorphic. And not only that, in other fields, the cytology or the nuclear cytology changes because we start seeing some epithelioid cells here, rounded and epithelioid cells with clear cytoplasm that seem to be clustering around these blood vessels. So more images of these areas. You can see they also form some peculiar patterns, what we might call as a linear group, or popularly known as the Indian filing arrangement. So we can see that here, almost looks like a lobular carcinoma of the breast. And these are intersecting in between the fibrous spindle cell areas. Okay, and we also see that the collagen is changing in character because it's denser over here. And then that's clearly seen in this image where you see the rounded epithelioid cells with the sclerosing or denser collagen that almost appears as if it wants to become osteoid. So very intriguing features. And then finally, I just wanted to show you that these are all occurring in the same tumor. So here is a zone of transition between the hypocellular or moderately cellular myxoid fibrous areas with the spindle cells and more hypercellular areas with the epithelioid or rounded cells that are growing or infiltrating in a sclerotic background. So with this appearance, of course, we want to think of some differential diagnosis. And this is a mind-boggling differential diagnosis because you saw the heterogeneity in the morphology. So just for the sake of completion, we know this is going to be a malignant tumor, but just for the sake of completion, let's say you got a biopsy from those very bland looking areas. So what differential diagnosis would you be thinking of in terms of a benign spindle cell lesion? Okay, so we start with neural tumors. Of course, neurofibromas can look like this without any particular architectural pattern. You can see some small spindled ovoid cells. That could be a neurofibroma. And in areas where it's more myxoid, there is a hypovascular stroma. And you also don't see that much of cellularity, very bland looking cells, so maybe a myxoma. And then perineurioma, because of the spindle cells in a whirling pattern, that comes in a differential. Then, of course, nodular fasciitis, the well-known mimic of sarcomas, where it can have hypercellular heterogeneous areas, myxoid background, feathery appearance. So that could be in the differential diagnosis. Then a deep fibromatosis, common in young women. So you can see these sweeping fascicles of spindle cells with characteristic slit-like vessels. So fibromatosis could be in the differential. And we also notice some cartwheeling or storiform appearance of these spindle cells. So DFSP could also be in the differential. But that's just for the sake of completion. I mean, I like this exercise because every time I look at these soft tissue tumors, I know most of them are very heterogeneous. I always keep thinking in my mind, what if the surgeon biopsies from this area? How would I make the diagnosis? What would my differentials be? So going through this exercise is very useful from my perspective, and I wanted to share it with you. So then let's get to the malignant differential diagnosis. What are we thinking about in terms of malignancy? What are these myxoid tumors? Okay, so myxofibrosarcoma, yes. So we saw these cellular areas with more coarser blood vessels, and of course a myxoid background. Even though we know myxofibrosarcomas are mostly in the subcutaneous plane and mostly in elderly patients, because of this architecture and cytology, we might need to think of that. And then we did see some focal areas where it was completely myxoid with more delicate blood vessels, where you might think of a myxoid liposarcoma. Of course, myxoid liposarcoma typically has immature fat cells, at least focally. So in the absence of immature fat cells, this would be an unlikely diagnosis. And then a malignant peripheral node sheath tumor, you have this marble pattern of alternating fibrous and myxoid areas, and some areas where you have high-grade spindle cell fascicles, so MPNST is in the differential. And then, of course, just a UPS because of the pleomorphism that we saw in some areas. And then our most important diagnosis here is going to be a low-grade fibromyxoid sarcoma, because we obviously saw areas that were fibrous and myxoid, and we saw these low-grade spindle cells. So that should definitely be in the consideration, and especially with the vascular pattern that was present in this tumor. And then in other areas, we did see these large collagen walls. So maybe we should be thinking of this entity that was called as a hyalinizing spindle cell tumor with giant rosettes. And then finally, we did see areas with the sclerosing stroma, with epithelioid cells infiltrating in almost like an Indian filing pattern. That would be classic for a sclerosing epithelioid fibrosarcoma. So these differentials are also very important to consider. So then with these in mind, our next step would be the ancillary test, immunohistochemical study. So I don't want to go through the whole list of all the markers we might be doing in this case. There is only one marker that will nail the diagnosis, and that marker would be MUC4, as many of you know. The MUC4 is a highly specific and I should say highly sensitive and very good specificity for this particular tumor. And we can see that even in the low cellularity areas, MUC4 is diffusely positive in a cytoplasmic pattern. And then in the higher cellularity areas, it is much better to appreciate because you can see a wall-to-wall diffuse positivity for MUC4. So with this morphological appearance, with this clinical presentation and the MUC4 staining, there can be only one diagnosis for this patient, and that is a low-grade fibromyxoid sarcoma. So low-grade fibromyxoid sarcoma was first discovered by or described by Dr. Harry Evans at the MD Anderson Cancer Center as a distinct variant of fibrosarcoma that's typically seen in the deep soft tissue of young adults. And these classically present with the features that we saw in many parts of our tumor: hypocellular, very bland looking, can easily be mistaken for benign tumors. Some cases, though, as we saw in our case, may demonstrate higher grade features, which are called as dedifferentiated low-grade fibromyxoid sarcomas. The most important thing to note about these tumors is that despite their bland appearance, they can show plenty of recurrences, and these recurrences can often be late. So about 60 to 70% of these patients recur locally if surgically not excised completely. And the other critical thing to note is that they can often present with metastasis. About 30% of patients present with metastasis at 7 years, and late metastasis again are very common. Documented cases of metastasis after 45 years of primary diagnosis are also there in literature. And as we saw, MUC4 is a lifesaver in these tumors because it can be easily mistaken for benign tumors, especially in small biopsies. So whenever you see a bland-looking spindle cell tumor, especially if the clinical history is a young patient with a larger, deeper soft tissue mass, then MUC4 should mandatorily be part of that panel. So that's an excellent marker. And of course, we know that LGFMS has a characteristic translocation between the first gene and the CREB-B3L2 gene. So that's about LGFMS. So what about this entity that we briefly saw as hyalinizing spindle cell tumor with giant collagen rosettes? So this tumor was described a decade after LGFMS was described by Dr. Sharon Weiss from Emory. And they saw that this tumor had actually similar clinical features to LGFMS and also similar gross and microscopic features, except for these very large giant collagen rosettes in some cases. In fact, if you look at the lower left corner of this picture, you will see that this morphology is quite consistent with LGFMS, except for these areas. So closer look at this collagen rosette, you could see that it almost looks like a flower, and it's surrounded by a palisading population of these spindle cells. In our case, also showed somewhat similar or comparable features where we saw these collagen rosettes and these spindle cells in the background. So not only do they have the comparable clinical and morphological picture, they also have identical immunohistochemical reactivity. So you can see here's a case of giant rosette tumor, and this is MUC4 in this tumor, and it's diffusely strongly positive. And they were also shown to have identical molecular features with the fusion between the same 716 first CREB-B3L2 gene. So as of now, we know this is simply a morphological variant of LGFMS and not a separate entity as such. Okay, and then let's move on to the other entity that we were talking about, the sclerosing epithelioid fibrosarcoma. So this was first described by Dr. Mees, again at MD Anderson. And she described a tumor that looked like almost like a lobular carcinoma, extensively collagenized stoma, where you have this linear groups of cells that look small, rounded, like epithelioid cells. Most cases look like this, but you can have some cases where the epithelioid cells are larger and start looking like poorly differentiated carcinoma. So here's a comparison image from our case, and you can see there is a morphological overlap with LGFMS where there is somewhat of a resemblance between these areas over here with these areas in SEF, and also these areas with the more poorly differentiated parts of SEF. Okay, so not just morphology. Again, we look at IHC and molecular overlap with LGFMS, and we know that MUC4 is strongly and diffusely positive in SEF as it is in LGFMS. And there has been a really good paper that's published that showed there are cases of LGFMS that show hybrid features between LGFMS and SEF. And in these cases, even though you often see first gene translocated with the CREB-B3, L2 or L1 gene. Predominantly, especially if the case has more of SEF features, you will see an EWSR1 translocation with the CREB gene. So that's something interesting to note. And then we also know that despite the similarities, SEF often tend to behave in a more aggressive fashion compared to LGFMS. That's because, as this paper showed, they often have the secondary genomic alterations in addition to the basic fusion that we see in these tumors. So we've long forgotten about the case that we were talking about. This patient actually came to us currently with a renal mass, and just to recollect, this is how the renal mass looks like. And by now, most of you must have recognized this. And we compare it with the remote case that happened in the calf. And as you can see from these images, they look very, very similar from field to field. And you can also see the so-called desmoplastic, or the stroma that appear desmoplastic may be similar to the stroma that we saw in the LGFMS that had these myxoid and fibrous areas. So IHC was done after this information was obtained. And of course, as expected, you can see a dramatic MUC4 reactivity in the small round blue cells that were infiltrating in the kidney, further tying together the leg mass that the patient had 7 years ago to the renal mass that she presents right now. And you can also see that we proved this by doing a EWSR1 FISH. And one of these cells, we picked this one. You can see there is a break apart between the green probe and the red probe, showing EWSR1 is indeed translocated, but there was no rearrangement of the first gene. So maybe this is a case that is leaning more towards the SEF end of the spectrum rather than the LGFMS end of the spectrum, even though we saw both morphological areas. So the final diagnosis in the kidney was a metastatic hybrid LGFMS with a sclerosing epithelioid fibrosarcoma. And finally, before we end this case, the kidney tumor was resected, and you can see the whole picture now. So essentially small round blue cell tumors, epithelioid looking, and then it interlaces with these LGFMS pattern with the fibromyxoid stroma and the epithelioid cells over here. And you can clearly see this in the high power view, where we have this lobular carcinoma like cells with clear cytoplasm adjacent to the fibromyxoid parts of the sarcoma. And then finally, another feature that has been described in rare cases of LGFMS, which ties together the radiological imaging that we saw of those coarse calcification, is actually the sclerosing stroma in SEF that went on to ossify and calcify. So it actually became bone. So this is an ossified sclerosing epithelioid fibrosarcoma in combination with LGFMS, which metastasized 7 years after the patient had the primary in her leg. So that's the end of case 2. I'd be happy to take any questions on this case.
Hello, Dr. Paari.
Yes, ma'am.
A wonderful case, really wonderful and very, very rare. Have you published this case?
No.
Is it,
no.
I mean, can we use it for reference, I mean, for that?
Yeah, of course. Sorry.
Any other place of metastasis tumor, or is it only kidney metastasis?
Yeah, I am glad you asked that question, because 2 years after she got the metastasis in the kidney, not 2 years, maybe 1 year after she got the metastasis in the kidney, she actually had soft tissue metastasis in the opposite limb. That looked again like LGFMS rather than SEF. So very, very interesting. I should have put up some pictures of that too. Yeah.
Thank you. Thank you for the
So that again underlines the degree of aggressiveness these tumors present with, even though they may have a very, very bland morphologic picture. And that is why it is so important on us as pathologists to identify these tumors correctly in young patients, so that they can get lifelong follow-up.
I mean, it's a very, you've done a extensive workup for this place. Though it was only mark 4, only one marker, but still to correlate with the previous, I mean, something nice actually.
Yeah.
Thank you so much for discussing this case in detail.
Sure, you're welcome. And also, as you have noticed, metastasis to the kidney in this type of small round cell pattern is not what one typically expects, right? So if this patient had a nodule in the lung, it's easier to think of metastasis rather than something in the kidney like this. So that also made this case more complicated.
That's why I asked, have you published this case so that we can use it for reference later. Thank you. Thank you so much.
Yes, of course. Any other questions, please? All right. If not, move on to case 3. So this patient is again another 60-year-old patient. She had a 10-year history of ecchymosis and swelling in her right foot. So imaging studies were done, and I can show you what the MRI showed. So here you can see in the metatarsal bones an ill-defined lesion with the fat signal characteristics, which measured slightly less than 5 centimeters in size. So the radiologist mentioned that it had this fat signal, and it also had these nodular areas that you can see over here, which were not quite like fat. And then you also notice some blood vessels. So based on the presence of fat and blood vessels, so the radiologist's preferred diagnosis was a hemangioma or a vascular malformation. So after this imaging study was done, the tumor was surgically excised. And this is part of the excision specimen that we are going to look at now. And you can see clearly this is made up of mature adipose tissue, and there is also some hemosiderin pigment scattered throughout this adipose tissue. Other fields, however, show a little bit of a different picture. You have spindle cell fibrous stroma that is intersecting in between the fat. So that looks different from what we saw initially. And there are other areas where the spindle cell fibrous stroma turns myxoid. And finally, we also have areas where there is a more fibrous collagenous appearance in addition to the adipose tissue and the hemosiderin pigment. So if we take a closer look at these cells, so the spindle cells look rather bland, and they are, again, intersecting between the adipocytes. There are few cells where you can see a little bit of hyperchromasia and some nuclear membrane irregularities. And then in the myxoid areas, we see these, again, bland-looking spindle and stellate cells with these linear vessels and some curved vessels looking very delicate. And then finally, closer look at the hemosiderin pigment. So we do confirm that it is indeed a hemosiderin pigment, which is present inside and inside the cells, and maybe a little bit in the extracellular region as well. So there are regions of this tumor that are more cellular than what we saw in the initial pictures. So if we focus on these areas, we can see this particular zone over here. The hemosiderin is very, very prominent, and you can see that it's mostly within the cell. It's all intracellular pigment. Okay, and then in these areas, we also saw some peculiar cells that were quite unexpected. And these are almost ganglion-like cells that are present in between these bland-looking spindle cells. Okay, if we take a closer look at those ganglion-like cells, we will see that there is some intranuclear inclusion. It's clearly seen here, and in this particular cell, the intranuclear inclusion is pretty large. So that's another unusual feature. Somebody is writing on my screen, which is nice, but yeah. So at this point, what are the differential diagnoses that we can consider? Okay, so we start from the very simple things. So maybe it's just a lipoma. We did see mature fat. And what about the hemosiderin? Maybe the hemosiderin is just reactive changes to the trauma. Maybe the tumor bled. Maybe that's what it is. But how do we explain the other spindle cells and the myxoid areas? We know that spindle cell lipomas can have this myxoid areas and spindle cells. So maybe it's a spindle cell lipoma. However, it would be an unusual site for a spindle cell lipoma. How about a DFSP? So the honeycombing pattern, as we all know, is characteristic of DFSP, where we see these spindle cell fascicles intersecting in between the adipocytes. And less likely, but at least we should be considering this, because we did see the myxoid zones and we did see the delicate curvilinear blood vessels. And this time we are also seeing some adipocytes. So maybe that should be considered in the differential diagnosis. So would immunohistochemical stains help us? Maybe it's something else altogether. So a basic immunohistochemical stain here, CD34, you can see it's strongly and diffusely positive. But CD34 as such can be positive in many fibroblastic lesions. So that's not entirely specific. We also did a CD68, which showed scattered reactivity, as you can see here. So maybe some of the cells are of histiocytic lineage. However, I want to say that this is essentially a morphological diagnosis, because we have everything we need to make this diagnosis in this particular picture. So we have the lipomatous component, we have the hemosiderin, we have the fibrous component over here in between the fat. So a diagnosis that fits all these characteristics will be what is called as a hemosiderotic fibrolipomatous tumor. Okay, so this is a rather rare entity, which is abbreviated as HFLT. It was described by Dr. Fanberg Smith back in 2000. Initially, when they described it, they thought it was a reactive lesion, and it typically occurs in ankle and in the foot region of middle-aged adults, especially females. We also saw that typical morphologic features that these authors had described in our tumor: mature fat, myxoid chain, spindle cells, hemosiderin, and the intranuclear inclusions. So everything was present. However, further studies in this paper that was published in 2008 did show that these are not reactive lesions. They do have a translocation, characteristic translocation between chromosome 1 and 10, where you have transforming growth factor beta receptor and then the MGA5 gene. So this was found in a majority of these cases. So we know now it's a true neoplasm. So this obviously is a benign neoplasm, although it can often occur locally, and sometimes it can also progress. So we're not done with this case because, of course, as we might remember, the radiologist did mention there were other nodular areas that did not look like fat. So what about those areas? What are we going to do with those? So here in this image, we see a high power view of those nodular areas. So you can see the HFLT areas in the periphery here and more cellular nodal areas in the center. And again, here, if we focus on the more cellular areas, we see that there are these fascicles of spindle cells as well as the myxoid zones, and we also start noticing some abnormal looking blood vessels. And then further images show us that these spindle cell cellular areas become so proliferative that they almost displace the fat out of the picture. So closer look at these spindle cell areas. Again, you can appreciate the high cellularity of these of this particular region, where you have the fascicles of spindle cells with abundant eosinophilic cytoplasm. And then I want to bring into picture these blood vessels that we briefly noticed. So these are abnormal blood vessels with clearly hyalinized walls. And then another area where you have the myxoid stroma along with some coarse-looking blood vessels, right? So myxoid area, coarse-looking blood vessels in the spindle cell tumor, which is displacing or invading this fat. So there were other areas that actually were quite concerning because, as you can see, there is quite a bit of pleomorphism in these foci. And then if we look closer, we start recollecting what we saw in the HFLT tumor, where there were these ganglion-like cells. In that, those areas, though, it was just scattered. Here we can see the entire field filled with these ganglion-like cells. And we also noticed the hemosiderin pigment that we saw in the previous case. And then more areas actually show an enhanced view, much more concerning. And we see these intranuclear inclusions, hemosiderin pigment, but the pleomorphism is much more concerning over here. But notice that there are no mitotic figures. And then let's briefly look at these vessels again, these characteristic blood vessels. So abnormal dilated ectatic vessels with fibrinous degeneration and hyalinization of the walls. Another image here showing the same picture, very abnormal branching vessels with hyalinized walls. And then yet another one just showing this fibrinous degeneration. And you see the spindle cell tumor in the background. And you also see a component of chronic inflammatory cells. So with this morphologic picture, some additional immunostains were done. And S100 was done because you're seeing all these hyalinized blood vessels and the spindle cells. So schwannoma could be in the differential diagnosis, but you could see S100 is completely negative, and there are a few dendritic cells that are staining in the background. But calpanin was different, and it's diffusely positive, maybe not as strong as the internal control, but it is diffusely positive. So maybe it's got some smooth muscle differentiation. That's a consideration. However, desmin was completely negative. You do see some scattered cells here that are positive, but this is non-specific staining in mast cells. Finally, CD34 again is very strongly and diffusely positive in this tumor. So with this picture, maybe we want to entertain some additional differential diagnosis. As I mentioned earlier, schwannoma is a possibility because we saw these vessels, we saw the spindle cells with alternating myxoid and more eosinophilic zones. And then because we saw the pigment, maybe we should consider melanotic schwannoma. And then we also saw this pleomorphism, uglier cells with intranuclear inclusions. So you never want to miss a melanoma. So that's, again, something that should be considered. Smooth muscle tumor, of course, we saw these fascicles of spindle cells, and also the tumor was positive for calpanin. So that would be a good thought as well. And then there is this new entity called the CD34 positive fibroblastic tumor. And these tumors, in addition to the spindle cells, can also show the type of pleomorphism we saw in this tumor. And of course, it's as the name indicates, it's going to be CD34 positive. So that's in the differential diagnosis. However, most of these tumors are also positive for keratin, which this tumor was not. And then finally, of course, we need to consider sarcomas. We did see these myxoid areas with these coarse blood vessels. So maybe it's a myxofibrous sarcoma that's actually infiltrating the subcutaneous fat. So that's a good location and a good age for myxofibrous sarcoma. So that should be considered. And then the more uglier areas that I highlighted, you might even think of a undifferentiated pleomorphic sarcoma. However, we have to go back to the morphology on this one. That's very important. So morphologically, if you just start naming what you see, that's going to make the diagnosis in the tumor. So we have these ectatic vessels with hyalinized wall. And then we have these pleomorphic cells without any mitotic activity. And then we have a diffuse intense CD34 positivity. So with these characteristic features in mind, an additional ancillary test was done. And this was for the MGEA5 break apart FISH probe. And you can see the positive control is over here where the green signal is apart from the red signal. And this is our case, which showed that MGEA5, which is now known as OGA, is rearranged or translocated. So this tumor is a pleomorphic here, hyalinizing angiectatic here tumor. Pleomorphic hyalinizing angiectatic tumor, PHAT. So that's the preferred acronym for this particular tumor. So this tumor was first described by Dr. Weiss and colleagues in the 90s. And as we saw in our case, they thought this resembled a schwannoma. And this typically occurs in the subcutaneous tissue of the lower extremity. And this is a classic morphologic description that we saw in our case. And this has a high rate of recurrence, actually 30 to 50% of patients recur. And that made the authors consider the possibility of a low-grade sarcoma. But we know what's tying this case together, right? So we already saw that this tumor was having this HFLT-like areas in the periphery. That's highlighted over here. And then we also have these more central areas that showed us the classic PHAT appearance, the pleomorphism and the angiectatic hyalinizing blood vessels. So this is a tumor that has overlapping pathological features, as we saw in this case. So both these tumors may be the same entity, and they show similar clinical presentation and anatomical location. And doctors Falp and Weiss actually did a fairly large study of these cases, compared these cases, and they showed that most probably HFLT represents areas of early PHAT. And this was further confirmed by the finding of the same translocation or rearrangement of chromosome 110 involving these two genes that we saw in our case. So it's that seems like a good way to tie up this case, but I'm still not done. So there are a few more areas I want to share in this case. And these areas, as you can see, resemble what we saw earlier, but you will see that the pleomorphism is much higher. The cells are much more hyperchromatic, and we have irregular nuclear borders. So this becomes very concerning for some kind of sarcoma. And if you just take the nuclear characteristics, you'd be thinking maybe this is a higher grade sarcoma, right? And then another image over here, again, shows you enhanced features and much more pleomorphic cells. But we also see this hemosiderin pigment. So these cases, some cases of HFLT PHAT have been shown to progress to myxoid sarcoma. So that is a known phenomenon. And when they do progress to myxoid sarcoma, many authors have said they actually resemble this entity called as a myxo-inflammatory fibroblastic sarcoma, or MIFS. And some authors also showed that some of these MIFS tumors show similar genetic changes to actually HFLT. However, I want to end with the fact that as of now, the relationship to MIFS with our HFLT PHAT entity with myxoid sarcoma is rather unclear. We don't know if they represent the same entity. That's because here is a classic case of PHAT with myxoid sarcoma. This is actually our case compared to this case of MIFS. So you can see there are some similarities between the two. But if you look at a textbook example of MIFS, this is what they will show. They will show these Reed-Sternberg or virocyte-like cells in a background of intense inflammation, typically plasma cell inflammation. You may also get some neutrophils and eosinophils. And fat with sarcoma never presents with these features. So maybe it's not the same entity. In addition, CD34, as we saw, is typically diffusely intensely positive in these tumors. In MIFS, it's only focally and patchily positive. And then the other clue is that we never see residual HFLT features in these cases of MIFS. So maybe they are not connected. So this is still hanging in balance. But anyway, so the final diagnosis for this rather complex case, this rare entity called hemosiderotic fibrolipomatous tumor with a pleomorphic hyalinizing angiectatic tumor with foci suspicious for myxoid sarcoma. So that brings me to the end of case 3. I have only one more case. Are there any questions, please?
Dr. Paari?
Yes.
Again, this is Dr. Vijayashri.
Yes.
A really wonderful workup and beautifully explained the relationship between HFLT and PHAT, because we did report a case in 2014 PHAT that had bizarre cells. It had bizarre cells, but no mitosis. The K67 was almost less than 1%.
Yeah.
And it did have areas of necrosis. And so we concluded with CD34 diffuse positive. I haven't published that case actually. So we reported as PHAT, just a benign lesion, that's it. So in case, if we have to look for malignancy, do we only look for mitosis, or I mean, in your case, you never showed any necrosis. So I was explaining to my students that unless you have necrosis, we don't think of malignancy. That is how I've been teaching also. So,
Yes,
but you didn't show any areas of necrosis. So how did you conclude that it is suspicious of malignancy?
Yes, yes. So that becomes very subjective, and I completely agree with you. The only definitive feature that can let you make the diagnosis that this is indeed a myxoid sarcoma that's arising in the background of PHAT is when you see some features that are really concerning, right? You should see an extremely high degree of pleomorphism, or you should see areas of necrosis or mitotic activity. So if you don't see those features, you can only guess or suspect that, okay, I'm seeing a degree of pleomorphism here that is concerning to me. That is, according to my threshold, more than what I would see in a PHAT. So maybe I should, just to be on the safe side, I should alert the clinicians that this patient should get more follow-up. I do not want to just call this benign and want this tumor to recur or come back in, God forbid, a metastatic location. So for that reason, so it's being a little bit more conservative to suggest that there might be a myxoid sarcoma change. But I completely agree with you. You should see some definitive criteria before you call it definitively a myxoid sarcoma.
Thank you for that. And I have one more question. Is it mandatory, or rather, is it very common to see these HFLT areas in an early PHAT? So in case I didn't see that, probably did I miss a foci, or because that patient is lost to follow up now, but I do not know whether the patient has developed any sarcoma in that. So I mean, have we gone wrong in warning the clinicians that may go for a sarcoma? Because I didn't see any area of HFLT in that. Is there any criteria?
No. I mean, I think it's rather rare for these tumors to actually turn into sarcoma. So it's not like 50%, 60% of them turn into sarcoma, right? So I don't think there should be a high degree of concern if you're convinced that most of the areas are convincing for like PHAT. It's okay if you don't see HFLT. If you see HFLT, then it offers further confirmation to your diagnosis, but you can make the diagnosis even with pure PHAT areas.
I think Dr. Femila will remember this case. She was with me when we reported this case.
Excellent, excellent.
Yeah, Dr. Paari, excellent case. I mean, a very unique one. I'm just wondering whether, as Dr. Vijayashki said, we might miss out some foci of malignancy, and at the same time, would it be confused for benign fibrolipomatous lesions, or are these hemosiderin pigments very prominent? I mean, is there any possibility that we may be missing the diagnosis somehow? Just a concern.
Yeah, usually the hemosiderin is very prominent, and then the location is also a very good clue. These tumors are rare in locations other than in the ankle foot region, so that may also help you. So if you get some tumor in the back, or some other location that looks like a lipoma but has a few hemosiderin pigment here and there, then you'd probably be considering more of a lipoma with trauma or something like that rather than a HFLT.
Yeah, exactly. Yeah, exactly. So in and around the ankle would be a very major clue, right?
Yeah. Yes. Yes.
Thank you so much. Thank you.
Sure. All right, so let me move on to case 4, my final case. This I'm almost out of time. I'm sorry about that. This is a rather fun case, so hopefully it will be quicker than the others. It's quite straightforward too. So this is a 54-year-old male who presented with a left forefoot mass. So he noticed for 5 months, and it seemed to be enlarging. So again, MRI was done, and here you can see this lesion. In contrast to the other cases that we saw today, you can clearly see that this is quite homogeneous in appearance. However, it is not superficial, because clearly it is present in between the tarsal bones, and it's going to the other side, and it measures about 3 centimeters in size. So based on these findings, radiologists offered a broad differential diagnosis. They said this could be a schwannoma or a granuloma, or could be even gout because of the presence in the foot, or it could even be a sarcoma because of its infiltrative nature, and you have to do a biopsy to confirm the diagnosis. And that's exactly what was done. And here you can see the biopsy, quite a peculiar tissue appearance, right? So you have this capsule at the very tip, which is a helpful clue that shows the circumscription of this tumor. It's quite blue, and in a higher power, you can notice that the blue character of the tumor is not due to the cellularity, but in fact due to the matrix. And the matrix is very, very interesting. So you can see these smudgy areas in the matrix, and it looks blue, sort of myxoid, sort of cartilaginous. So it's really difficult to say. And there are also these scattered multinucleated giant cells in here. And if you look at a higher power, you can appreciate the matrix better, very smudged nature of this blue grungy appearing substance. I don't even know what that substance is. Again, could be cartilage, could be something else. And then these cells are quite bland appearing, even though they appear hyperchromatic. It's a very high powered picture. You can see from here that this is a hypocellular tumor, and the stellate and spindle cells are quite bland appearing. And then let's focus a little bit on the multinucleated giant cells. You can see closer to the fibrous septa over here, there are many almost osteoclast-like multinucleated giant cells. And then other areas actually do show a transition to perhaps what is more closely resembling chondroid matrix now. So maybe this is trying to change into cartilage. And then finally, we see areas where there is some dirty appearing or grungy appearing calcification. So this is granular calcified material, which is better seen in this high power view. So that's what we have from the biopsy. So based on this, what are the differential diagnoses that we could potentially think of? So this is far out there, but gout was suggested by our radiologists. The location also is not too bad for gout. And we do often see these multinucleated foreign body-like giant cells in gout. And if you look closely at this matrix, maybe there are some negative images of needle-shaped crystals. So that would be something that we could think about. But as you know, the gout matrix, even if the crystals are washed away, it's going to be more eosinophilic rather than basophilic like this. So it seems unlikely. And then we did see these areas of calcification, this granular type calcification. So tumoral calcinosis is not an uncommon phenomenon. So maybe that is what is happening. And then we also saw these chondroid or cartilaginous appearing area. So it is quite close to the bone. So maybe it is something that is arising from a periosteum or even the soft tissue. So you do get soft tissue chondromas. That is something to consider. And then a very rare entity, chondromyxoid fibroma. You do have a chondroid myxoid type matrix with these bland appearing spindle cells. So maybe it is subperiosteal chondromyxoid fibromas. So with these thoughts in mind, we also need to consider other possibilities that we have not discussed so far. So some immunohistochemical stains were done. So you can see that this particular immunohistochemical stain is strongly diffusely positive. This is actually CD56. And then I also have ERG. ERG, as you know, is a very good marker for endothelial cells, but these tumor cells, in addition to some of the blood vessels, are positive. And then finally, I also did a SAT-B2, which is strongly and diffusely positive in the tumor cells. So SAT-B2, as you know, is a very good marker for colon cancer, but it's also a good marker for cells of osteoblastic derivation. So that was diffusely positive in this case. So the additional features in this case that we need to look at are the clinical and laboratory findings, and not just the morphology and our ancillary tests. So these were very interesting in this patient. He actually presented with chronic femoral stress fractures, osteoarthritis, and thoracic spine pain because of collapse of the thoracic vertebra. And the DEXA scan actually showed that he had mild osteopenia, and the vitamin D was also deficient, which was later on corrected. So could this actually be all tied together? So could this be some sort of tumor-induced osteomalacia? So with this differential diagnosis in mind, we did offer a diagnosis, and then the tumor was resected. So before we go to the diagnosis, let's look at the resected specimen. So here you can see that this tumor appears encapsulated, it appears well circumscribed, and the substance of the tumor itself is nicely lobulated in with this blue matrix-like substance that we know so well now, and it also had some areas of hemorrhage. Then if you look at some other areas in the periphery, though, you see it's not actually that well circumscribed. There are some little pseudopods that are infiltrating into the adjacent adipose tissue. So these lobules are really well defined, and they are surrounded by these fibrous septations, which also contain blood vessels, which is better seen over here. And in some areas, the blood vessels even appeared like some stag-on structures. And the calcification was much more prominently seen in the resected specimen. So this classic dirty or grungy calcification was present in many areas. And in some zones, it also formed these peculiar floret or flower-like crystalline appearances. And then
5 days.
5 days. Coffee tea and separate.
Coffee.
And then in some areas, we could see that the calcification actually congealed to form some larger structures in the tumor matrix. So there were other things that were seen in the resected specimen that were not quite obvious on the biopsy specimen, like this area, for example, where you seem to see have some pink matrix that was almost osteoid-like in combination with the blue granular substance. And then other areas, this part we did see in the biopsy some chondroid-like elements. However, in the resected specimen, this actually turned to cartilage, and it's pretty clear that this is cartilage. And if you look at a closer image, you will see that there are chondrocytes in chondrocytic lichens. So this is definitely true cartilage that is forming from this tumor. Then there were areas of hemorrhage that we noticed in the lower power picture. So this shows some cystic zones. And then if we take a closer look, we will see that there are plenty of these osteoclast-like multinucleated giant cells, many of which have numerous nuclei. And we also have some spindle cell fibrotic stroma around these areas. And these seem to extend into the blue matrix. So there are areas where the cellularity of the spindle cells extended into the blue matrix, and it can be clearly seen over here. And there are a few vessels in here as well. So with this appearance, just for the sake of completion, let's go through another list of differential diagnosis. So maybe we should actually be considering the possibility of chondrosarcoma here, because we did see well-defined cartilage. And sometimes chondrosarcoma, especially if it goes into higher grade, can transform into myxoid areas that look a little bit different from the opaque cartilage that we see here. So that's something to consider. And then we had areas with multinucleated osteoclast-like giant cells. So maybe it was a giant cell tumor of the bone that was somehow not present in the bone. It was present in the soft tissue adjacent to it. Seems a little bit far-fetched, but at least from this morphologic picture, that may be under consideration. And then, although not seen in our particular case, many of these tumors can show expansion of these spindle cells with prominent HPC-like blood vessels that might bring solitary fibrous tumor into the picture. So that's another thing that should be considered. Again, we go back to the clinical and lab workup. This time we have more definitive answers, and we have this particular serum element. This is fibroblast growth factor 23, which is highly elevated. And then this patient's phosphorus was also reduced, and alkaline phosphatase was increased, showing increased bone turnover. So with this morphologic appearance, immunohistochemical staining pattern, and this lab workup with his history of osteomalacia, there is only one diagnosis for the tumor, and this is called a phosphaturic mesenchymal tumor. An extremely rare tumor. Incidence is less than 0.5%, and it's very fascinating the way this tumor works, because there are hardly any other soft tissue tumor that actually have an endocrine effect. So this was first described way back in 1987, and these particular mesenchymal tumors were known to cause osteomalacia rickets in younger people, and these typically occur in middle-aged adults. And as I mentioned, this is one of these unique soft tissue tumors that have an endocrine manifestation. And now we know that majority of mesenchymal tumors that actually cause tumor-induced osteomalacia all belong to this PMT group. We thought there were several different tumors that could cause TIO, but now we know that they're all different morphological manifestation of the same tumor, which is the phosphaturic mesenchymal tumor. And the very interesting part on how they actually cause this osteomalacia is because, as we saw earlier, they secrete FGF23, and this FGF23 inhibits renal tubular phosphorus reuptake. So phosphorus is lost, so calcium phosphate cannot be formed, and so the bone starts degenerating and breaking down. And then the other thing that we need to know is we had a positive SADB2 in our tumor, which actually suggests osteoblast lineage in the tumor cells. And we know osteoblasts are a known source of FGF23. So maybe that's where this tumor is producing this FGF23. And we also know now that these are true neoplasms, which actually have a fusion gene between fibronectin 1 and fibroblast growth factor 1. And this chimeric fusion protein actually increases the amount of FGF23 that's produced by the tumor. And finally, clinically, these tumors all behave in a benign fashion. There are very rare examples of malignant ones. And as you might have guessed, the tumor-induced osteomalacia always resolves after the tumor is excised, as happened in our patient. So that brings me to the end of my challenging case presentation. Again, please, your questions are welcome if you have any on this case.
Paari, wonderful case. It was really a wonderful case. But I thought at one point of time, I knew it was a phosphaturic mesenchymal tumor, even in the first two, because of grungy calcification. But then I thought you're stressing on the point that it's going to go for malignant transformation when you talked about the chondroid areas and the spindle cell areas. So was there any area of malignant transformation in this? And what type of malignant transformation do you normally expect in these?
No, there was no malignant transformation in this particular case. Yeah. So some cases they could develop this pleomorphism in those spindle cells, and they could present as malignancies, but this case did not have any malignant transformation.
Yeah, we have reported one case in our institution a couple of years back, and as you said, they present more to the endocrine department. And they're very rare tumors. Yeah, very
I remember Dr. Sunday, it was presented in CHETPATHCON.
Yes, absolutely. Yes, yes, true. Just one case across so many years. Yeah.
Yes.
Very, very, very distinct tumors and very distinct presentation. I mean, you have to think about it. Like it,
Yes,
they said there has to be a degree of suspicion.
Yeah. Yes, and these are the type of cases as a pathologist, it gives you
Yes.
great satisfaction when you make the
Absolutely.
diagnosis and when you can explain to the endocrinologist and the orthopedic surgeon what is happening.
Yes.
You remove this, the patient's osteomalacia will disappear. So
I must say that you had such an excellent set of cases, Dr. Paari, and it's such a proud moment for us from here, you know, because you put out some excellent cases, and we feel so proud that you're part of our state, and shared your knowledge to such a great extent, and we feel so proud that it has been conducted under the aegis of Tamil Nadu Pondicherry chapter. Once again, enjoyed your talk and enjoyed the cases. Very beautifully explained. Amazing.
thank you, ma'am. It is completely my privilege. I'm more than honored to be among all of you, sharing our interesting cases.
So what do you think is the specificity of SATB2, sir? Like you mentioned that the SATB2 was positive here in the areas of osteoblastic differentiation.
Mhm.
So how specific do you consider the immunohistochemistry marker SATB2? What is your experience on that?
In this particular context, with this type of matrix, SATB2 is very specific. That's my thought, especially with the clinical picture. If you put it together, SATB2 just confirms the diagnosis for you. But of course, you have to be careful with SATB2 because anything that has an osteoblastic presence will elevate the SATB2. So any bone tumor that you take, you do SATB2 staining, you will get some positivity. We do use it for osteosarcoma sometimes, especially when it's completely fibroblastic. It is often helpful, but typically SATB2 is not very specific in the setting of a bone tumor.
Okay, thank you so much, sir. It was an excellent presentation, fully worked up cases. So it was actually an enjoyable one. Thank you for all.
You're welcome.
Paari, thank you so much. Thank you so much for sparing time and for extensively preparing and working on the cases and sharing with us all your expertise and your experience as well. We look forward for some